Moving on to endocarditis, this is inflammation of the endocardium, particularly the endocardium that lines the surface of cardiac valves. Now recall that the heart basically contains three layers. There's an endocardium, there's a myocardium, and then there is a epicardium. Remember that the endocardium lines the inner surface of the heart. It's basically a single layer of cells sitting on top of a basement membrane. They're basically endothelial cells. And that this endocardium also lines the surface of the cardiac valves as they project out. And so in endocarditis, you're going to get inflammation predominantly on the surface of those cardiac valves. Now this is usually due to bacterial infection, not always, but usually. The first high-yield bug to be aware of is Strep viridans. This is the most common overall cause of endocarditis, and it is a low virulence organism. Now that's important because, number one, therefore, it can only infect previously damaged valves. For example, if the valve is damaged by chronic rheumatic heart disease or mitral valve prolapse, then and only then will this low virulence organism be able to infect it. And number two, because it's low virulence, it results in small vegetations that will not destroy the valve. And so that's particularly high yield, but all of that's based on the low virulence of the organism. In fact, the endocarditis caused by Strep viridans is also called subacute. Now the pathogenesis is that because you've got a previously damaged valve, that damaged endocardial surface will expose subendothelial collagen and tissue factor underneath it. That then allows for the development of thrombotic vegetations, and those vegetations, of course, contain both platelets and fibrin. Now these vegetations, they act as a trap for bacteria whenever there's transient bacteria in the blood. So for example, let's say that there's a dental procedure and that forces bacteria into the blood. Some of those bacteria can then be trapped in these thrombotic vegetations on the heart valves, which will then result in infectious endocarditis. And that's one reason, for example, the classic teaching was that prophylaxis with antibiotics, for example, during the time of a dental procedure, could theoretically decrease the risk of endocarditis in patients with damaged valves. Staph aureus is the most common cause of endocarditis in IV drug abusers. It is a high virulence organism, therefore it will infect normal valves and it will result in large vegetations that destroy the valve. Hence, it causes something called acute endocarditis. Now, important to know that the classic valve that's going to be involved by Staph aureus is the tricuspid. Again, the idea is that the IV drug abuser has contaminated skin and then shoots up through the contaminated skin. When they do so, the Staph aureus gets into the vein, gets drained into the right heart eventually, and then hits the tricuspid valve and will damage the tricuspid valve. Here's a picture of Staph aureus endocarditis. You'll notice that these are very large vegetations sitting on the cardiac valve, and of course this is also called acute endocarditis. Staph epidermidis is important because it is the key bug that causes endocarditis of prosthetic valves, so that's the high yield there. And Strep bovis is important because it is the key bug that causes endocarditis in patients with underlying colorectal carcinoma. Now this is very high yield for board exam purposes, even for clinics for that matter. If you have a patient with endocarditis who ends up having endocarditis due to Strep bovis, the next thing you need to do is check for colorectal carcinoma. And so that's a particularly important association for board examinations. Now it's also possible to get endocarditis with a group of organisms called the Hayseck organisms. This word basically represents the key organisms that can cause this type of endocarditis. They include Haemophilus, Actinobacillus, Cardiobacterium, Eikenella, and Kingella. And the key thing about this endocarditis is that it gives you endocarditis with negative blood cultures. And that's, of course, because these organisms are particularly difficult to grow. And so, again, endocarditis with negative blood cultures, think about the Hayseck organisms. Clinically, irrespective of the cause of endocarditis, patients generally have fever, and they also have a murmur. Now, the reason they have a murmur is because they've got these vegetations on the cardiac valves, which is then going to disrupt flow across those valves. In addition, they can get septic embolization of the vegetations on the valve. Now, again, the idea is that if this is the valve coming off the wall of the heart, you've got these vegetations sitting on top of the valve, and of course, the vegetations are going to be flapping up and down with the valve. And so these vegetations can be shot off into the circulation, and when they're shot off into the circulation, that would eventually result in septic emboli of these tiny pieces of bacteria. Complications of septic embolizations include Janeway lesions, and these are erythematous non-tender lesions on the palms and the soles, and Osler nodes, which are painful lesions on the fingers or toes. And the way to remember this is ouch, ouch, Osler. and so that's the one that's painful, if that helps you. In addition, you can get splinter hemorrhages in the nail bed, and that again would be due to septic embolization. And so these are some of the key findings that arise with septic embolization. Now, finally, the patients can also have anemia of chronic disease. Of course, they've got chronic inflammation because they've got this infectious endocarditis, which can then lead to anemia of chronic disease. Now, the laboratory findings are that the patient will generally have a positive blood culture. There will be the findings of anemia of chronic disease, and just recall that if they have anemia of chronic disease, that's going to be generally a microcytic anemia. And so the hemoglobin would be low because there's anemia. The MCV would be low because it's usually microcytic. Of course, in this particular case, you've got acute phase reactants being released by the liver. One particular acute phase reactant would be hepcidin. Remember, hepcidin is high yield. It traps iron in the storage sites. And so when iron is trapped in the storage sites, the ferritin will be high. Because the ferritin is high, the TIBC will be low. And in addition, because there's no access to iron from the storage sites, the bone marrow will begin to take iron from the blood. And so the serum iron will decrease and the percent saturation will decrease. Now, in addition, transesophageal echo can be used for detecting lesions on the valves. And this is a very good way to be able to look for those vegetations on the valve that are so characteristic of endocarditis. Another type of endocarditis is called non-bacterial thrombotic endocarditis. The name tells you a lot. It's not due to bacteria. Instead, you get thrombotic vegetations on the cardiac valves. These are sterile vegetations. They generally are associated with a hypercoagulable state or an underlying adenocarcinoma in the patient. These vegetations usually arise on the mitral valve along the lines of closure, and they'll result in regurgitation. Liebman-Sachs endocarditis is particularly high yield. We've discussed it previously. This is where you get sterile vegetations in association with lupus. Now, the most important thing here is that if you've got this valve, you get vegetations on both sides of the cardiac valve. And when you get vegetations on both sides, that's highly characteristic of Liebman-Sachs endocarditis. Again, it usually involves the mitral valve, and it's going to result in mitral valve regurgitation. And that completes our section on endocarditis.